Today, we are getting into a really fascinating and frankly, clinically critical topic. We're talking about the unexpected risk of adrenal insufficiency after a unilateral adrenalectomy.
For years, the guiding principle in adrenal surgery has been pretty simple, almost reassuringly so. The idea is, if you take out one adrenal gland, for say a non-secreting tumor, the one left behind has more than enough spare capacity to pick up the slack.
But what if that core assumption isn't always right? What if that supposedly healthy gland on the other side is, well, stunned into silence after the surgery? That single question, that one possibility, changes everything, and it's exactly what we're going to unpack today. So here's our game plan. We'll start with that established premise. Is one gland really enough? Then we'll look at the surprising evidence that's challenging it. After that, we'll dive into the pathophysiology, figure out how to identify patients at risk, and wrap up with what this all means for management and patient counseling.
Okay, so let's start at the beginning, with the very foundation of our clinical practice, this belief that one healthy adrenal gland is all you're ever going to need.
And this quote, wow, it really captures the certainty that has dominated our thinking. The message has always been crystal clear, almost dogmatic. For things like non-secreting tumors, cons, or PHIOs, post-op adrenal insufficiency just shouldn't even be on our radar.
And look, this belief is grounded in solid physiology. It makes sense, right? We know the adrenal glands have a massive functional reserve. As long as you have intact HPA and RAAS feedback loops, you'd fully expect that one remaining gland to just ramp up production and compensate for its missing partner. Case closed.
But then came the data. Let's move on to the evidence that really started to unravel this long-held certainty.
And this chart right here, this illustrates the disconnect perfectly. For Cushing's, yeah, of course, we expect adrenal insufficiency in pretty much 100% of cases. The HPA axis is suppressed. For non-secreting tumors, we expect, well, basically 0%. But what have multiple studies actually found? An incidence somewhere between 27 and 34%. That is a massive, gaping chasm between what we expect and what's actually happening to our patients. That's really important to point out that in most of these cases, the hypocortisolism is transient. That stunned gland does eventually wake up. But let's be clear, transient does not mean benign. That period of insufficiency, however long it lasts, still carries a very real clinical risk. And if you need a number to drive that point home, here it is. One prospective registry found an adrenal crisis rate of 6.9 per 100 patient years in this population. I mean, think about that. That's a life-threatening emergency happening at a rate we see in patients with known established AI. This is not something we can just brush aside. So having seen that surprising data, the next logical question is, why? What is actually going on here? Let's try to unpack the pathophysiology. This table gives us a really nice high-level view of the different scenarios. After a bilateral adrenalectomy, it's simple. You have no tissue, you have permanent primary AI. With Cushing's, it's HPA axis suppression causing a transient secondary AI. But for the supposedly non-secreting tumors, the mechanism is totally different. It looks like a sudden, unmasked reduction in functional reserve. So if we dig a little deeper, a few hypotheses are floating around. Maybe that contralateral gland just had poor reserve to begin with. Or perhaps the stress of surgery itself temporarily tanks its capacity. But honestly, the most compelling theories revolve around this idea of a stunned gland from some subtle hormonal crosstalk. Or, and this is a big one, the presence of undiagnosed subclinical Cushing syndrome.
And that brings us to SCS, the great confounder in all of this. We're talking about a tumor that we've classified as non-secreting because it passes our standard workups, but it still might be pumping out just enough cortisol on its own to quietly, slowly suppress the other gland over time. Then you take out the tumor and bam, that suppression is suddenly revealed.
So this brings us to the really tough part, the central clinical challenge. If we know this happens in up to a third of our patients, how in the world do we figure out which third before they get into trouble?
And the frustrating but honest answer from the literature is this: we don't have one. There is no standard, validated protocol to prospectively identify these at-risk patients. We're flying a bit blind.
So what does the evidence suggest we can do? Well, it turns out that things like the patient's age, their BMI, even the size of the tumor, none of that seems to be predictive. What can be helpful, though, is checking a post-op day 1 cortisol level or maybe even doing a post-op ACTH stim test to see who has that impaired reserve.
But even that gets complicated because the timing here is so tricky. For instance, one study found that while 4% of patients had low cortisol on day 1, most of them were back to normal within a week. This just highlights not only how transient the problem can be, but also the very real clinical risk of over-treating patients with steroids they might not actually need long-term.
All right, so this all leads us to our final section, and really, the clinical imperative. Given all this diagnostic uncertainty, how do we actually manage this risk and counsel our patients effectively? What do we do on Monday morning?
Well, the consensus seems to be pointing toward a proactive 3-step workflow. First, we have to change our pre-op counseling. This risk needs to be part of the conversation. Second, we should have a really low threshold for post-op monitoring, whether that's with a simple cortisol level or a stim test. And third, and you could argue this is the most important, we need to provide incredibly robust discharge education.
And that education piece is just so critical. Because, let's be honest, the symptoms of adrenal insufficiency, fatigue, weakness, no appetite, they sound a whole lot like a normal post-op recovery. We have to arm our patients and their families with the knowledge to spot the difference and know exactly when they need to call us or get to an ER.
Which leaves us with this final, really provocative question. Given that up to a third of these patients are at risk for transient AITA, and that there's a non-trivial risk for adrenal crisis, and that we don't have a reliable way to predict who's going to be affected, is it time to consider routine post-operative ACTH stimulation testing as the new standard of care for every single patient undergoing unilateral adrenalectomy? It would be a fundamental shift in our practice, but it's a shift the evidence strongly suggests we need to start seriously considering.